going to have a session today that looks at the past, the present, and the future. You'll remember that we had a timeline yesterday about the past 40 years. At the end of this session, we're going to be doing an activity that is the future, the next 35, I think, if I did my math right. So stay with us on this. I'm introducing the plenary, which is Equity and Empowerment when Communities Own Their Own Future. And this is a really appropriate plenary. We're celebrating, as we noted yesterday, the 40th anniversary of Where There Is No Doctor. This is also a milestone year for primary health care. It's the 35th anniversary of the Alma Ata Declaration and primary health care, and the 25th year of the Nepal Female Community Health Volunteer Program. So we're going to be hearing about all of these themes today. Because most of our speakers are going to be referencing primary health care and the Alma Ata Declaration of 1978, I thought it would be useful to just quickly review and refresh our memories about that. It was in 1978 a global commitment to achieving health for all, and that primary health care was the strategy that the world got behind to achieve that. So all of our presentations today are going to be speaking about how we have done and where we need to go. Here's a summary of the steps towards health for all that WHO identified, again, just as an overview. And these are really themes that we've been touching upon in this entire core group meeting. So that's just a little bit of an overview to the session. This is my presentation, and I will be speaking about primary health care and an agenda for the future. So as many of you know, I am with Hesperian Health Guides, and we are identified with primary health care and have been a big actor in primary health care for many, many years. Where There Is No Doctor is viewed by many as the Bible or the blueprint for how to carry out a primary health care program on the ground. Here's a summary of the kind of Alma Ata, or the spirit of Alma Ata. The vision being health for all by the year 2000. Key principles being accessibility, affordability, and acceptability. And key strategies, which I think we're going to all identify with: community mobilization, appropriate technology, and multi-sectoral cooperation. Now, we have achieved many things in the past 35 years. And unfortunately, with a short presentation, I don't get the opportunity to celebrate all of those achievements. We're actually going to be hearing two speakers that are going to give us quite a lot of depth about that. And we're going to be pulling a lot of lessons learned from those presentations that we can apply to the future. So there's one lesson, though, that I did want to underscore, which is this. One lesson that I think we cannot forget, and that's a central theme to this plenary and, frankly, to this entire core group meeting, is that despite the marvelous advances that we have all made in our work, that we have seen happen in the past 35 years in health and in health systems, the reality is that it is factors outside of the technical realm and factors outside of the health system in general that have been primary challenges in achieving health for all. And Geeta Rao Gupta yesterday very eloquently pointed out in her keynote speech, in a way that is not going to be coming from as eloquently from me, is that what we need is political will. What is really required is political will. Now, the key to getting that political will is civil society, an empowered, mobilized, activated communities. That is actually the key towards achieving the political will necessary to ensure that health for all can be achieved. So I do hold this lesson in mind and hope that with this in mind, you'll allow me to share some modest thoughts for a future primary healthcare agenda with the rest of my presentation. So the first is, my first modest contribution is that an agenda for the future of primary health care needs to look at ways that we can foster community mobilization in our programs and in our work. The issue is community mobilization that's on their terms, not necessarily ours. And that can be really challenging, as any of you who've really worked on the ground know. This happens to be a slide from Spain, a Spanish protest about immigration, healthcare access for immigrants that was last month. But I think this vision of a mobilized community has to become more of an integrated part of our understanding of primary healthcare. We're going to be hearing lessons that Laura and Ram are going to be sharing with us and the rest of this plenary that are going to talk more about how we can achieve that. Okay, my second modest agenda point for primary healthcare and its future is this. Primary healthcare is not where there is no health system. And forgive the pun on where there is no doctor. But we all know that we need to work to connect and integrate community health workers into the larger health system. I think we all understand that. But how do we do, for me the key is, how do we do that in a way that still allows communities to feel the pride and the ownership and the sense of self-reliance that comes from a community-led project? And I think that that is really a challenge for us looking at the future of primary health care. How can we connect and integrate community health workers and community health projects into that larger health system while fostering community initiative and not having it feel overwhelmed by the health system coming down and imposing onto the community? So Ram's presentation is going to speak about the Nepali community health volunteers, and I think he's going to give us some good lessons to draw from that will help us think about this in the future. Okay, my next modest contribution to the future agenda of primary health care is this. What does community look like in an urban setting? How do we approach community health care in an urban setting, primary health care in an urban setting? You know, our vision of primary health care for the past 35 years is something that is usually taking place in a rural community, in a rural village. But with population, demographic shifts, urbanization, our agenda for the future of primary health care has to look at how to build and mobilize communities in a much more complex and overlapping reality that is an urban setting, rather than the relatively homogeneous rural village that's self-defined by geography. We need to be looking creatively at how to build and make community happen in these very different ways and still have it reflect and look like the primary health care that we want in these much more fluid definitions of community. Here's a few examples. Okay, here's another modest challenge for us going forward. Non-communicable chronic diseases. Now, and the table over there, yes, our NCD working group, yes. They are a challenge for that primary health care must address in the future. They're a health challenge that are currently and increasingly being felt by the communities that we serve with primary health care. It's a challenge, but it's also an opportunity. Non-communicable chronic diseases are an opportunity. When you think about it, community health workers are perfectly suited for dealing with diabetes and hypertension and some of these other issues that are persistent in a community. And frankly, they are going to be the key to how to prevent health systems from becoming totally overburdened by the situation of NCDs as that increases. Because of their understanding of local resources, the ability to build community and trust and rapport, and their existing communications and relationships within the community, community health workers play a critical role and can play a critical and unique role in dealing with NCDs. Here's a brief summary is they can handle both an integrated approach to prevention and education, but they can also deal with screening and referral. They can support people who are on treatment, and they can help them manage their care and do prevention for secondary or increasing or worsening health conditions. They can create and facilitate peer support for lifestyle change, and they can deal with community organizing that's really necessary to address the underlying issues that are preventing people from making those lifestyle changes, whether that's helping organize a vegetable garden, a community vegetable garden, or organizing exercise groups. It can be very varied, but that is really a role that community health workers can play. So I guess what I'm saying is if we can think about what integrated management of childhood illnesses has done, and think about how we've incorporated that fully into the primary healthcare vision, think about what we can be doing with integrated management of NCDs at that community level. So one additional contribution there. I'm just going to throw out one more, which is mental health, just a modest one. Some people are calling it part of the NCD agenda. I think thinking about mental health promotion and what community health workers can be doing with mental health promotion, it remains for me an additional agenda item for the future of primary health care. Okay, here's another one. I know I'm preaching to the choir on this one, but I think it's worth remembering and thinking about and reflecting on the logic of integrating early childhood development into primary health care.